Okay, folks, we're going to start our next session now. Everyone can come on back in and we'll get going here. We are really privileged today to hear from two leading conservatives, two doctors no less, who are on the forefront of thinking about what comes next after Obamacare. Representative Tom Price and Representative Phil Rowe have plans that would dismantle the top-down, one-size-fits-all approach to health care that's been imposed on our country by Obamacare. And instead, it would focus on the delivery of health care by focusing on consumer demand, consumer choice. You know, you all know, a lot of you are part of the conservative movement, there's a tendency to focus in the movement on the different details of different plans, and we sometimes will obsess over them. But the truth is that there is really a lot more in these different plans that are being presented here today and others that are percolating throughout Congress and in the conservative think tank world. There's a lot more that unites us on this issue than there is that divides us. We all agree we want to provide choices to the American people. Healthcare should be patient-centered. We all agree that the market does a better job of driving down prices than do federal mandates. Healthcare should be affordable. And we all agree that freedom should be the centerpiece of any new health care plan. Health care and our relationship with our doctors should not be coercive. Both of these plans that we're going to talk about today embrace those principles and put us on the path to reform. So please join me in welcoming Dr. Tom Price to the stage to talk about the first one.
Thanks, Tim, so much. Good morning, all. I think it's still morning, maybe noon. Great to be with you, and great to be back at Heritage. Heritage does such a great job in so many areas, and healthcare, which is near and dear to my heart, is certainly one of those areas. Patient-centered healthcare, which is what the topic is, and how do we get patient-centered healthcare? It's important to think about what patient-centered healthcare is. What is it? What it means to me is that as a physician for over 25 years taking care of patients and families and doctors taking care and making medical decisions, not Washington, D.C., or not insurance companies. Patients and families and doctors ought to be the ones making medical decisions. The very troubling activity over the last 3 to 4 years is that what we've seen from the administration and what we've seen from Washington in so many corners is that we're moving away from, not even on the right trajectory, to get to patient-centered health care. We're moving away from allowing patients and families and doctors to make those medical decisions. Now, interestingly, I think that conservatives have actually won the debate on the president's health care law and tax. I think we've won that debate. By overwhelming numbers, the American people say they don't like the patient's health care law and the taxes that go along with it. But they want a new solution, and that's what we're here to talk about today, positive solution. And they exist. They exist all across the Republican perspective. There are over 150 pieces of legislation, healthcare legislation, in the House of Representatives alone, 150. So when you hear the president say, if anybody's got a better idea, we'd like to sit down and talk about it. Well, the fact of the matter is we've asked the president over and over and over to sit down and talk about it, and he has refused at every single turn. I want to touch briefly on the principles of health care and then talk specifically about H.R. 2300, a bill that I've introduced now for the third Congress in a row. First, principles. What are the principles that we have and hold dear for health care? If you think about them, it's important that we follow those principles. You may think that you don't have health care principles, but everybody does. Everybody. Most people have the top three. We need a system that's accessible. Everybody needs to be able to get into the system. We need a system that's affordable. Everybody needs to be able to afford it in some way. And we need a system of the highest quality. Those are usually the top three: accessibility, affordability, and quality. I add three more to those. I add responsiveness. It doesn't do you any good to have a system where if you walk through the front door, nobody's behind the desk. That doesn't help anybody who's in need from a healthcare standpoint. Innovation. If we don't have innovation, if we don't incentivize innovation, then we don't have the highest quality. In fact, people are going to have to go elsewhere for the highest quality because we're stifling innovation. And then choices. The American people want choices and have a right to have choices in health care. Who's going to treat them, where they're going to be treated, how they're going to be treated, when they're going to be treated, all those kinds of things. So accessibility, affordability, quality, responsiveness, innovation, and choices. Those are the 6 principles that I believe we ought to make certain we adhere to. And regardless of what your principles are, I suggest that if you look at the president's law, that his law, current law of the land, violates every one of those principles. Decreasing accessibility, increasing costs, which means decreasing affordability. Quality, you talk to my medical colleagues, my former medical colleagues, they shudder because they're seeing a decrease in the quality of health care that's being provided. Not because doctors and other providers have forgotten how to care for patients, but because of the system is making it so quality is that much harder to be able to provide for individuals. Responsiveness, innovation, government health care, you decide. I don't think responsiveness and innovation tend to go in the same sentence as government run often, and in this instance they certainly don't. And then choices, fewer choices, and we hear about this day after day after day with the president's law. The choices are being limited, who you're going to be able to see, where you're going to be able to be treated. So if those are the principles, and we step back and you say, yes, that's what we agree on, those are the principles that we agree upon, then let's look to solutions that actually support those principles, adhere to those principles. H.R. 2300 is the bill that I mentioned that I've introduced now 3 Congresses in a row. There are packets, I think, in the back or in the right outside the room, and you're certainly welcome to pick them up. They describe the bill in some significant detail. H.R. 2300 is the work product of the Republican Study Committee 2 Congresses ago. So when the president was coming forth with his law, I was privileged to chair the Republican Study Committee at that time, and we got together about 20 or 25 people who had an interest in health care within the Republican Study Committee, many physicians, other folks who had been working in health care for a long time, and came up with our alternative at that time. It's been refined and I think perfected over the last 2 Congresses. But it does a number of things, and I want to touch on 3 or 4 specific things because it does the kinds of things that the president's law does not do. First, you got to get folks covered. You got to get folks to have that accessibility to care and to coverage and affordability of care, of coverage. How do you do that without putting Washington in charge? It's relatively simple. H.R. 2300 says that every single American ought to have the financial feasibility and incentive to purchase health coverage. You do that through the tax code, tax deductions, tax credits, refundable tax credits, advanceable refundable tax credits, so that every single American, regardless of their economic station whatsoever, have the financial ability to be and incentive to be able to purchase coverage, and it's coverage that they want for themselves and for their family, not that the government forces them to buy. No mandates. Remember, you as an individual, every single American knows best what kind of coverage they ought to have. There's no way the government can have a one-size-fits-all program because it fits nobody. One size fits nobody is what it turns out to be. So you can get everybody covered. Second, we've got to solve the insurance challenges. There are real insurance challenges that existed before the president's law. There are more coming online right now. But the 2 big ones are portability and pre-existing. You ought not lose your insurance if you change your job or you lose your job. That's a holdover from a bygone era when if you worked for a company, you usually and they provided health coverage, usually worked for them for 30 or 40 years, and you just kept your coverage. Young people in this audience, young people in this country right now, the statistics say that they will work for between 12 and 15 different employers in their lifetime. There's no reason whatsoever that they ought to have 12 to 15 different health care policies, health coverage policies, if they don't want. We ought not have a system that forces them. This is an easy one to solve. You simply allow every single American to own their coverage regardless of who's paying for it. So if you change your job, you lose your job, you just take it with it. Portability. It's like a 401k plan. You don't leave your pension plan at a previous employer, do you? No, you take it with you. Portability, easily solved. Pre-existing illness, this is one that is a real serious problem. Nobody in this country ought to be priced out of the market for health coverage if they get a bad diagnosis. That's a system that may work for government, it may work for insurance companies, it doesn't work for patients. Remember, patient-centered. If we think about the problem and diagnose the problem appropriately, we recognize that there are really about 18 million people who fall into that risk. If they have a bad diagnosis, then they may be priced out of the market tomorrow. Those are the folks in the individual and small group market. Those are the folks for whom they don't have a big pool. They don't have large groups of individuals assisting and purchasing coverage together so they can't drive down the cost. How do you solve that without putting Washington in charge? You make it so those 18 million people look like the others for whom a pre-existing illness isn't a problem. That means that you create Robust pooling mechanisms, not just high-risk pools, where you take all the folks with an illness or a difficult problem and you put them in one pool and you wonder why the price goes up. No, robust pooling mechanisms so that anybody who wants to pool with anybody else, we call them individual membership associations, so that you can purchase across state lines, you can join with others across state lines to be able to get that purchasing power of millions so that one individual's adverse health status doesn't drive up the cost for that person or anybody else. And then finally, we waste huge amounts of money in this country in health care. The biggest way that we do that is through what's called the practice of defensive medicine. As I mentioned, I was a physician. I was an orthopedic surgeon who spent over 25 years taking care of patients. It's what I did. It's what every doctor does if he or she is honest with you. And it's the extra tests that are ordered and examinations that are ordered. And they're not done to harm you at all. But what they're done is solely so that if that doctor ever finds himself or herself in a court of law, that they can honestly look the judge and the jury in the eye and say, I don't know what you wanted me to do because doggone it, I did everything. When in fact everything was rarely necessary to either diagnose or to treat the patient. Now, the standard line on the conservative side for how you take care of the lawsuit abuse in our country is a cap on non-economic damages. I'm here to tell you there's no study in this country that exists that demonstrates anything that a cap on non-economic damages decreases the practice of defensive medicine. How much does defensive medicine cost? There are a couple studies out there. Jackson Healthcare has a reputable study, estimates it's 1 out of every 3 healthcare dollars. That's $800 billion. $800 billion. That's not over a 10-year period of time, ladies and gentlemen. That's 1 year. That's every year. You add that up and see the amount the number of dollars that we are wasting in the area of healthcare. It's unconscionable. So what do we do if we make the right diagnosis, step back and look and see what the real problem is? You got to make it so that doctors, if they do the right thing, if they order the right tests and do the right thing as it relates to a patient, not because of what the Secretary of Health and Human Services said, but what scientists and their colleagues in that specialty society say, based upon appropriate guidelines. If they do the right thing, they ought to have a safe harbor, essentially, in a court of law. They ought to be able to use that as an affirmative defense, to go into the court and say, I did exactly what I should have done as it relates to the problem that this patient presented to me. If you use that as an affirmative defense and you raise the bar, you raise it to clear and convincing evidence instead of a preponderance of the evidence, then what you do is begin to chip away at that culture of the practice of defensive medicine. Remember, wasting $800 billion a year. So look what we've done. H.R. 2300 gets everybody covered with insurance that they want, not that the government forces them to buy, solves the insurance challenges of portability and pre-existing without putting Washington in charge, and saves hundreds of billions of dollars, all without putting Washington in charge or raising your taxes by 1 penny. 1 penny. And the solutions that are in H.R. 2300 are included in a number of other pieces of legislation. There's a lot more that we have in common than not. What we don't have in common with the current law of the land, though, is that we stick to principle. We stick to the principles of affordability, accessibility, quality, responsiveness, innovation, and choices. If we do that, I have great faith and confidence that what we will ultimately end up with in this country is a system that is truly patient-centered, where patients and families and doctors are making medical decisions, not Washington, D.C. Thank you so much.
Thank you, Dr. Price. And now please join me in welcoming Dr. Rowe to the stand.
Well, Tom didn't leave a lot for me to say after that. I agree with everything. I'm a co-sponsor of his bill. So, first of all, thank Heritage for having me here today. I mean, for those of y'all who don't know who I am, this is starting my 6th year in Congress. I spent 31 years practicing medicine in rural East Tennessee. And we started with a group of 4 doctors. We now, because of managed care and other issues that came up, grew our practice to 100 physicians and 450 employees. We went from 4 doctors and 12 employees to that. And I one day came home to my wife, who is a nurse, and I said, Pam, I'm either going to quit complaining or I'm going to try to go to Washington and do something about it. And friends of mine asked me, Phil, they said, why why in the world did you decide to run for Congress? You were mayor of a local town. You had great medical practice. And I'm going to tell you the truth. I went off my medicine after coming to this place. And if anybody wants to run, tell them my medical license is still good, and I'll write them a prescription if they need it. So Tom did a great job in outlining this. I got here in 2009, just as the healthcare debate opened up. And I still find this the most astonishing thing about the healthcare debate of all. We had 9 physicians at our health caucus, doctors caucus. We have 15 now. Not one of us was asked one thing about the health care bill, what we thought about it. And I guess naively so, I thought, having gone through health care reform in Tennessee with TennCare, I thought I had something to offer to the debate. I can tell you what not to do. And unfortunately, nobody cared. And basically, this Affordable Care Act that we're dealing with now is TennCare on steroids. You could not have written anything more complicated than this bill. I don't think you could have sat down and said, let me write something as complicated as I can, because the simplest transaction in the world is where a patient calls my office, comes in and sees me and leaves and pays the bill. That's no more complicated than buying a loaf of bread. And yet we've made it now, you have to tie everybody into a pretzel to try to get health care. It's unbelievable what's happened to our system. And let me tell you, I'm going to pass a couple editorialize along a little bit. I'm in a town of 65,000 people. We are a medical referral area. Our local hospital system has 9,000 employees. We've had almost 1,000 layoffs in our local town. Let me tell you, those are the best jobs in town. Vanderbilt University has laid off 1,000 people this year and cut the size of their MD, their medical school class, and cut their MD, PhD program by 10%. Does anybody in the world believe that the quality of care goes up when you cut the size of your medical school classes and you cut the size of your future researchers in those classes? It's unbelievable, and you can repeat this story all over the country. And when they tell you it's creating jobs, that is absolute nonsense. This bill is creating chaos, I can tell you right now, among the medical community. Well, last year, this past year, Steve Scalise, who's the chairman of the RSC, which Tom has been, came to me and said, Phil, I want you to chair a committee, which Dr. Price was on. He said, I want you to chair a committee and write a Republican study committee alternative to the Affordable Care Act. And he said, I want this bill to have no mandates. It has to cover pre-existing condition. It has no subsidies, malpractice reform, and equalize the tax treatment. I said, gosh, is that all you want me to do? So anyway, we sat down and got to it last year. And this committee, I want to go over just a moment the people that were on it, because they did a great job. Marsha Blackburn from my great state of Tennessee, Renee Elmers from North Carolina, John Fleming, Dr. Fleming from Louisiana, Dr. Paul Gosar, who's a dentist from Arizona, Dr. Tom Price from Georgia, and Todd Rokita from Indiana. I've never been on a committee that worked harder. And we looked at the principles and things, Tom mentioned, things we had all agreed on. And I'm going to go through these fairly quickly. It is a patient-centered, and the premise of the Affordable Care Act is absolutely spot on right. You want it to increase access and decrease costs. And lastly, I would say, as Tom pointed out, to let the decision-making occur between doctors and patients. And I'm going to use myself as an example here in just a minute about how this actually works. There are just 6 titles to this bill. And I brought a couple things on. Well, I thought some of you, I've looked around the room. Some of you do not. But some of you know what a Sears and Roebuck catalog looked like. I can tell by looking at you. I know you're old enough. Well, the Affordable Care Act, I calculate, is about 2 Sears and Roebuck catalogs, if you've seen. Remember, they were about this thick. This is SGR reform right here, just how we pay doctors. We just finished working on this last week. That's it. And this is a 180-page American Healthcare Reform Bill, 181 pages long, that anybody can read in an hour and a half. What does it do? The first thing it does is repeals the Affordable Care Act. We have to get rid of this monstrosity and repeal it. I can tell you, Dr. Price and myself and others have spent, as you all have too, I have spent hours trying to think. When I go home, they say, Doc, well, can't you just tweak it? Yeah, with a nuclear bomb, but other than that, you can't tweak this thing. It's impossible to do, because you'll mention one thing, and I will tell you 4 things that it's going to do that will change what you just tweaked. So we have to repeal it. That's number 1. And number 2, I think a lot of you all, and this is to my Baptist friends out there, think the original sin occurred in the Garden of Eden. The original sin occurred after World War II when they treated companies different than they did individuals from a tax standpoint with health care. So what our bill does, it equalizes the tax treatment for an individual and for a company. I'll use myself again as an example. When I worked for Medical Center OBGYN, my group, I could provide myself health insurance at pre-tax dollars. I retired 6 years ago to run for Congress. That's when I went off my medicine 6 years ago. And the next day, I had to pay first dollar. It cost me more money the next day. So what we do with this bill is that we say, okay, each family can take a $20,000 deduction for health insurance. If you find a standard deduction for health care, if you make $60,000 a year, your taxable income is $40,000. And if your health insurance premium, and that makes it portable, as Dr. Price talked about, if your insurance is, say, $15,000, the $5,000 you still get as a deduction, you'll get money back. And that's from payroll taxes and your income taxes. So we do that to start with. We massively expand health savings accounts. We started health savings accounts back, that's Title II. We started those in our own practice. Now almost everybody in our practice, those 450 people we provide insurance for, selects a health savings account. Why? Because it puts the doctor and the patient. I had to have some biopsies. I use a health savings account. I have a debit card. I didn't call the insurance company to find out if I could go down to the outpatient clinic and get anesthesia for these and have the biopsies done. My doctor said I needed it done. And it is kind of scary when you let one of your medical school classmates operate on you, which is a friend of mine, and I did that. And I knew I needed it done. He knew I needed it done. I went down there, and I said, I want the cheapest price you've got. And in a second, they had their money. They didn't fool with the insurance company, nothing. That transaction was taken care of. And let me pass a little something along about the Affordable Care Act that is unknown. And after this year, when the ERISA-based people, the 70 million out there that have an individual policy, lose their non-grandfathered status, 40%, and I checked with Vanderbilt, and I checked with my own very large medical center, over $1 billion in revenue before I came up here. 40% of the uncollectible debt that hospitals have in our area are people with insurance, because the out-of-pockets are so high now, people can't afford to pay them. So they've got catastrophic coverage, but they don't have a health savings account to cover it. What we allow you to do is to fund up to whatever your out-of-pocket is, up to $12,000 a year for a family, so you could cover your out-of-pocket. We increase it for people on Medicare, for people who are disabled, for veterans who don't have that option. So we do that. And as Dr. Price mentioned, one of the things, and we have no mandates for a 26-year-old. That's the great mantra. Well, a 26-year-old, and I had to buy all three of my kids an individual policy before they actually got a job with health insurance. But let me tell you what you can do if you can buy it across state lines. 26 states already electively do that. You can make that decision yourself and buy what you need. And right now, the federal government tells you what you have to buy. I'm going to be a little graphic here now, okay? Let me tell you why that's important, why that's driven the costs up through the ceiling. I have been fixed. My wife has been fixed, okay? We got 3 kids. Both of us determined that if we thought we had to raise another kid now, we would jump off the Capitol hand first into the parking lot, face first. You got the idea, don't want any more kids. But I have to buy pediatric dental coverage, pediatric vision coverage, infertility coverage, OB coverage, of which I don't need any of. And those are the reasons that you buy with a health savings account and a catastrophic policy what you and your family need. So we do that. And with health care reform and with malpractice reform, we also include that in our bill. The other reason that's important, I'm going to pass along our Tennessee experience. When we started in 1975, when I got out of the Army and came back to Memphis to finish my training, all the malpractice carriers left the state, every single one of them. And we set up a mutual company, the doctors did. Over half of the malpractice premiums we have paid into that company since its inception went to lawyers. It didn't go to the injured party. That's terrible. We need a way to be sure and to take people who have been injured by the system and pay them. We don't now. Our state set a cap of $750,000 in 2011. The first full year after that implementation, the physicians in that state and ultimately the patients who pay those bills, and we're not a big state, our premiums went down $100 million in 1 year. 1 year. The practice of defensive medicine is going to take longer, as Tom pointed out. There's no question about that. So across state lines, association health plans, we all agree. Transparency wasn't brought up, and that's in Tom's bill. That's very important. This bill requires that the HHS secretary tells us what they pay for something. So if I go in with my debit card, I can know what is being paid there. I mean, you don't go buy a suit of clothes and then you buy it and they tell you what it costs later. I mean, that's how health care is purchased. It's ridiculous how it's done. So this transparency. The other thing we do in this bill, which is very important, is COBRA. COBRA right now, Bill Gates can't afford when you get it, so nobody can buy it. But what we do is if you have had a plan and had no disruption, you don't have to exhaust COBRA if you have a pre-existing condition to buy a cheaper plan. High-risk pools were mentioned for patients that, look, there are just people out there that have conditions that are incredibly expensive to treat. We have to realize that, and as a society, we're going to treat them. We're either going to shift those costs or we're going to man up and say those costs are there. So we fully fund a high-risk pool. And we also do not allow any funding, federal funding, or using your HSA for abortion services. So that's basically in a nutshell what our bill is. It's an easy bill to read, 181 pages. It will increase access, and I can tell you right now it will decrease cost and put some certainty back. This is the most, I've been a doctor for 44 years this year. This is the most uncertain I've seen our profession since I have been there. Expert senior physicians are looking for exit signs, and that's not what they should be doing. They should be looking to see their next patient. I want to thank you all for being interested, and I can tell you this, that man sitting right over there has not given up the fight, and I have not given up the fight because the American healthcare system is the best in the world. No question about it. The miracles I could tell you, and I will pass one along, and I'll sit down because I want to hear your questions, is when I was a medical student in Memphis in 1969, 1970. I went to St. Jude's Children's Hospital. That was my first pediatric rotation. I can still remember children I saw at that hospital. 90% of those children died. 90% died. Today, 90% live. That is a miracle. That when the Lord walks on the earth again, the first step he takes will be at St. Jude's Children's Hospital, I'll tell you that. It is a phenomenal place. Every child is treated for free. Every parent is brought there for free. It doesn't get any better than that. The question is, are we going to shut off that innovation that created these cures for families out there that I've seen, these babies that I delivered? And then, I forgot to tell you, I'm an OBGYN doctor, and I delivered most of my own voters, so it worked out pretty well for me. With that, I will sit down. Thank you all.
Thank you, Drs. Rowe and Price, and thank you for your commitment to repealing Obamacare and leading on the reform efforts that we really so badly need to talk about. I'd like to invite the rest of our panel up right now. Grace Marie Turner and Nina Ocharenko are two of the leading experts on this issue in this town. And they really are all over the place. They testify before Congress. They're published in various places, and they're in demand on the Hill with a lot of these members who want to know how to push their reforms forward. So we're lucky to have them as part of our panel. I'll kick it off with a question, and I think I'd like to direct this question to Nina and Grace Marie just to start with. As I kind of noted at the beginning, there are some technical differences between these bills. How do we, as the conservative movement who are interested in pushing reform, how do we deal with the technical differences between the bills and the principles, and how do we push forward on this?
You know, there are a lot of calls for Republicans to get behind one bill. Why can't you agree on one bill and pass that? Well, I will tell you that Republicans do not have a better idea of how to write 2,800 pages of legislation that raises $1 trillion in new taxes, that still leaves 30 million people uninsured. They don't have a better idea how to do that. So what they need to do is exactly what Dr. Price and Dr. Rowe were talking about, is help the American people understand the vision of what they do, not just the specifics of the bill. You can get very bogged down. There's some minor differences between Dr. Rowe Dr. Price's bill and some of the others that are out there, if you focus on that, and that's what you do if you start with legislation, then you wind up having people never understand what the core ideas that unite all of them. And I think they both described very clearly, it's about putting patients in charge, it's about real choice, it's about true competition, all the things that Obamacare promised, but none of which they're really delivering.
And I would just add, too, that if you look at how the process went for delivering what we have today, it was all done behind closed doors and just appeared for a vote on the floor. We need to kind of go, I think we've forgotten what it was like to go through a normal legislative process. Let all the bills go through a markup. And then that's the process in open hearings and markups that members can get together and say, yeah, I think this is where we're going to move forward. And then move that to the floor and move from there. I think that creates the momentum you also need to really get something passed that not only do the members all agree with, but that also have the confidence of their voters when they're voting on it.
One more question from me. Obamacare took a lot of our labels. They stole them from us. Choice, freedom, that kind of stuff. What are the labels that Obamacare stole from us that are the most important for us to get back, and how do we do it?
It's the entire dictionary of healthcare policy. They've taken our game plan, used our top line talking points to conceal their liberal policies to enact this healthcare law. So whether it's choice, competition, security, you can go through the list one after another, portability, all these things. The question is, what is the real defining meaning of those words? And I think that's where we're different. And I think many times, we've all said, no one thought that the healthcare system before the healthcare law was perfect. So we all agree there was a problem. It's where our solutions are that create such vast differences between what this healthcare law is and with the plan that, that these congressmen and others are putting forth.
And I think that Dr. Price said, that we've won the debate because the American people see the flaws and the problems with Obamacare. But I think we have won the debate in a different way because the other side really had to use affordable choices, security. We're going to make sure that you can keep the plan, you keep your doctor. We're going to, all of the promises they made were really things that we've been talking about for the last at least 15, maybe 20 years. But they put this mountain of rules and regulations underneath it that takes it in a completely different direction. So getting back to those principles, telling the American people that this is what we really would do to get to affordable choices by having genuine competition, not fake competition, genuine choice, genuine portability, having you decide what kind of health plan you want, not having it be dictated by the federal government. I think that's really what we do is get back to the real principles of that work in the rest of the economy, not these fake labels that really have deceived the American people.
Did you want to add something? Okay, we can open it up. Or sorry, did you want to add
Let me just
something?
comment, if I may, on the process and on how you get this done, and Nina touched on it. None of us, look, H.R. 2300 isn't going to be the piece of legislation, the RSC proposal from this year isn't going to be the piece of legislation, but what ought to be is allowing every single legislator, every single representative, and every single senator who has an interest and has a passion for assisting in solving this, to work together in the normal process, the due process and the deliberative process of legislation. It's what, as Nina said, wasn't done. We don't want this to be a partisan piece of legislation. We want this to be a bipartisan piece of legislation. We want every single member who has an interest to come together and put their 2 cents in it and work it in the amendment process in both the committees and on the floor. That's the way you get to a solution that can be embraced. We've seen what partisan gets you. We're in a position right now where partisan gets you. That's not the place to go.
Well, just a very brief comment. The thing that still astonishes me after being in Washington for 5 years is that health care is a Republican or a Democrat issue. It blows my mind. I've never seen a Republican or Democrat heart attack in my life, or never operated on Republican or Democrat cancer. And I have delivered a lot of Republican babies, I will tell you that, where I live. But I almost had a Joe Wilson moment at the last State of the Union when the president, for the umpteenth time, had the audacity to stand up and say Republicans have no ideas, when that's all we've worked on for years now. And we were at the retreat just recently. We attended in Maryland, and the principles that the leadership laid out are in Tom's bill and my bill too. The solutions are health savings account, medical liability reform, across state line purchases, high risk pools. All of those are with some variation. And as Grace Marie said, if you look and nitpick these things, you'll never get it. But what we've asked for is to grow through regular order, go to the committees of jurisdiction, debate it robustly in the light of day, bring it to the House floor, debate it robustly in the light of day, and then give an up or down. And look, the bill I wrote, I understand, should be amended. I don't even agree with everything here. It's open for amendment as opposed to the 80 amendments the Republicans brought to the Affordable Care Act, and not one was ruled in order. I had 10, not one single one got a hearing on the House floor. That's not the way you get a system where there's buy-in of all, because it is not a Democrat or Republican issue. It's an American issue.
Thank you. Okay, let's open it up for questions. Yes, sir.
Obamacare has, what, 6 feet of regulations? Tell me. Obamacare has 6 feet of regulations. Tell me, if you repeal it and then move to something else, what happens to all those 6 feet of regulation? Take me through the mechanics of going one from what Obamacare to something else.
Well, when we repeal the law and replace it with something that works for patients and families, then there will be new law that will have to have the regulations stipulated and rules written for it. However, what they would do would be much more permissive, flexible for individuals, so that you have a new system. It's a culture that is in Washington right now in many areas that says Washington knows best. The Health and Human Services, the CMS, believes that Washington knows best, that it can make the best decision for patients. We simply don't believe that. In fact, I know it's not true. And so if we were to have our druthers, and when we get to our legislation being passed, and I think it will be because the current law can't stand, when that happens, then there will be a culture within that system that will say patients and families and doctors ought to be the ones in charge, not Washington.
The question was, what happens to those 6 feet?
They go away.
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 Because they would conflict with current law.
You're aware of that
Yeah.
they'll go away.
Yeah, because they would be in conflict with current law, and then current law.
I suggest we all join for a massive weenie roast if that happens, to burn it and get rid of it. We are in a process now of the most disruptive time in my lifetime in healthcare, the most uncertainty. And all patients want is they want to come to their doctor and get their problem taken care of. I mean, that ain't complicated. I did it for 30 years. And we have so complicated. And the other maddening thing about this bill to me is the Affordable Care Act, is the billions of dollars we've spent on stuff, infrastructure and websites that don't work, that I can't take this pen and write one person a prescription for. We have literally spent billions of dollars and have nothing to show for it except a failure.
Mm-hmm. Okay, right here.
Thanks. So you're going to have Obamacare repealed. That's what's going to cause it to fail. How is it going to get repealed unless the Senate goes Republican and we get a new president? Because are you going to require that it's just going to get so bad, so oppressive before 2016 that it's just going to collapse?
Our preference is to repeal the law, there's no doubt about it. But we understand that with Harry Reid in charge in the Senate and the president still in the White House, he's not going to sign a bill that says repeal his signature legislation. The problem that we have right now is that real people are getting hurt because of this law. Real people's lives are being destroyed, not just from a healthcare standpoint, but from an economic standpoint as well, because of the law. So what will happen, I believe firmly, is that in 3 to 5 years, we won't be living under this piece of legislation, this law, because it doesn't work. It doesn't work for employees or employers. It doesn't work for doctors or patients. It doesn't work for the states. Certainly doesn't work for the federal government from a financing standpoint. So there will be a clamor to repeal and replace. Now, whether that happens after the next presidential election or before, because the law fails to be implemented. There's so many delays and postponements and changes in the law right now. We haven't even seen the worst of it yet.
Because now they're talking about the individual mandate being extended past 2016.
Delay.
So they
The
just
delay.
keep changing the law.
Changing the law.
But I hear in your question that you're thinking that by repealing it, Republicans would therefore be responsible for the law failing. The law is failing of its own. We have a paper on our website, 34 major changes already made to this law, 17 of them by the White House. That's an acknowledgement that it's not working. And almost every day now, we hear some new rumor about more changes that are being made. So it's not working. It's wrong for America. It doesn't work. We've got to start over. And the American people now understand what they want. They know Obamacare's not delivering it. That's why we have to start over.
Go here and then there. Go ahead, Jim.
A question, actually two questions. One, the portability aspect of new legislation, how much does it conflict with state-level management of health insurance and state-level mandates that differ, of course, widely? How do you reconcile the federal?
The provision that we have, portability, you own your own health coverage regardless of who's paying for it, has all of the things that have a 10th Amendment contest, potentially. We stipulate that anybody that has a nexus for their health coverage with the federal government, then that's where it applies. So, for example, if our individual membership associations, which would have a nexus with the federal government because it allows purchase across state lines and allows larger, non-economically aligned individuals to purchase coverage together, then that they would be able to own that. Individuals who are in any ERISA plan, they would be able to own that. So it gets to that by making certain that everybody who has a nexus with the federal government, which is virtually everybody.
One other quick question. I think we've seen how much patients and prospective patients are resistant to this law and the damages. Looking at industry, healthcare industry, pharmaceutical companies, hospitals, clinics, how much pushback is Congress hearing from these organizations in terms of the damages, or are some of them still supporting Obamacare as they did at the outset?
Here's,
for their own
I can speak to that a little bit. It was a private conversation I had Friday with someone who is extremely knowledgeable in the hospital realm. And he believes that several hundred hospitals across the country are going to go out of business. And I think certainly when they change the way critical access, where only one hospital is funded differently than another one within a 10-mile radius or whatever the radius ends up being, those other hospitals will go away. And I look at my own community, we've already lost one. Lee County, Virginia is closed. There could be many others. There will be many hospital closures. And when you look at these hospitals, they're looking at partnering, getting bigger and bigger and bigger. There's going to be massive consolidation and bankruptcies in the hospital business. There's no question about it. It's going to happen.
I would just add, too, you can look at the participation rates among the insurance plans into the exchanges. Many of them have kind of sat on the sidelines. So I think even though they may not be verbally saying, you can look at what their business model is looking like moving forward. And I think we may not know everything today, but as these years move forward, we're going to get a good sense of where the marketplace falls at that point.
Great. We're back here.
I want to applaud you on your long game strategy. You actually have to seed the grass in order for it to grow. And you have to change people's minds about things. But that is a longer game because you got 3.5 years or more left to get to the finish line. What are you doing? What do you have in mind to do between now and then? There's something called the Regulatory Accountability Act that allows Congress not only to initiate legislation, but actually to review regulations adopted by the agency to see whether they're ultra-virus beyond the authority that Congress delegated. And then you can look to see whether they're working or not and basically point out how they're not. So in other words, you've won the battle of making the American public aware of the problems. You haven't won the battle yet of selling your ideas going forward. So by further going into the regulations and making them account to Congress, because they have to, because you've delegated authority to that agency, have they met your delegation? And I would probably tell you you'd find that they have not, and that they've gone ultra-virus, and you can have all types of investigations and all types of reviews and evaluations of how badly these ideas in regulatory form are being implemented.
Connie, do you want to make?
Well, first of all, there are a lot of court challenges to
Yeah.
the way that the regs have been written in contradiction to the actual statutory language. But I actually think you may see that the problem you've got now is that it has to also get through the Senate. And that's a real
That's
barrier.
legislation, not your.
Well, the regulatory,
acting-
and
you have a
Congress is,
tool in
Congress is holding countless hearings on regulatory oversight. They're passing legislation in the House, most often with significant Democratic support, to try to move forward and to try to and sometimes put into statutory language what the president is trying to rewrite the statute to say, such as the delay of the individual mandate and delay of the employer mandate. But I think that the Regulatory Review Act, or that's what it's called,
Yeah.
is actually is an important tool, but it still requires getting that legislation through the Senate.
Yeah, but you have sound bites with that
Yes.
opportunity.
Yeah,
You
that-
have sound bites every night on the news that you can point out another regulation that's been either poorly implemented or implemented beyond your delegation.
Couple
That's-
points. I think you're spot on, and I think we could be doing a whole lot more. A lot of what we do doesn't get covered, and so folks don't know that we're doing it. But this is so onerous and so oppressive to the American people and harming real people. That I think there ought not be any limit to what we're doing from a regulatory oversight standpoint. Second point I would make is that the other thing that we will do is our leadership is committed to making certain that we do in fact have a piece of healthcare legislation. And Phil mentioned kind of the Venn diagram center where everybody has the common theme, and its expansion of HSAs, purchase across state lines, association health plans, some med mal reform, those kinds of things, so that the American people can see that we're not just fighting to make certain that the American people know how awful the current law is. We have positive ideas, positive solutions that they can point to and say, hey, that's the kind of thing that we need.
I would just add one more thing, that, this issue about regulation is not something that's in isolation to healthcare. And I think it can create a great message to the American people, because I think they are skeptical. What is going on in Washington? How are all these rules being changed? We have many that are guidances that are driving what people are doing, interim, final rules. Very few are getting really, I think, to the final stage. And so all that ambiguity is creating greater uncertainty. But it's not just in healthcare. It actually, I think, is rampant across all the regulations that this administration is using. So could be a good opportunity to move it outside of the silo of healthcare and really framing it in a different way.
Are you familiar with the REINS Act? I think as Jeff Davis is in the previous Congress, and I'm not sure, I think Reed Ribble or somebody has it this time, but boy, you talk about a game changer. Because I didn't know there's 4 branches of government, but that's the regulatory branch. You're absolutely, all the bureaucrats up here that do stuff that I didn't know what they did in all these buildings. Now I'm finding out they manage every phase of your life. And everybody has got a story about how these regulations add to cost and create incredible cost to business, not just in healthcare, but in everything. I could tell you stories of builders that I have, friends of mine who are in the construction business. And the REINS Act says if you have a rulemaking that affects the U.S. economy by more than $100 million, which many of them would, it has to come back to the Congress for reapproval. That would stop that stuff in its tracks. Mm-hmm. Could you speak in the microphone?
You also have the problem, if you rely too heavily on the courts, there's a doctrine called the Chevron doctrine, where they basically, the courts defer to the expertise of the agency.
Yes.
Now, that's gone way overboard, beyond anyone's wild imagination, where nobody even questions, and the standard of proof to get beyond the agency's deference is great. In fact, too great to make any type of change. So that's why Congress has a role here, in addition to the court system.
Thank you. Right here? Yes, sir.
I'm a believer in repeal and replace, but also realistic that the only time that Obamacare gets repealed or replaced is by replacing Harry Reid and then Obama himself. So over the next 3 years, well, first of all, we've got to do something in 2014, but over the next 3 years, people will continue to feel the greater pain. I mean, just personally, when the president says I can keep my 2 sons who are under 26 on my health insurance, and then I get the premium, and it's literally $10,200 for the year for both of them, that other people are facing the same thing, 38% increases in premiums and so forth. So that pain is going to keep going up, but is there, and maybe this isn't the right forum, but is there a conscientious effort in the House in joining with the Senate to try to get a net 6 first so that we can control the Senate in 14? And then is there some, as we were just talking about, a longer-term plan, a 3-year plan, so that, I regret to say, I don't think your bills will become law, but, you know, what's the plan? Do your plans work in 3 years? They could be working now, but will they work in 3 years after 3 years of devastating costs?
Free market's been working for centuries. Yeah, they'll absolutely work. And if just given a chance, the most regulated market in the world, and it began with Medicare, is healthcare. I mean, people talk about, I went to Tom and I went to this think tank last year in Fort Lauderdale. And the guy was talking about how the free market. I said, free market? Are you kidding me? I mean, everything is based on what Medicare pays and what Medicaid pays in the state, and how you bill the insurance companies paying off that for their payments. So it's totally regulated. If you can get some, and let me tell you what I think is going to happen in the real world. And you're beginning to see it now, and it's unfortunate. Look, some of the most fun and best patients I took care of were people who never paid me a nickel. I live in rural Appalachia, and I took care of anybody that walked in the door. That's what I did as a doctor. It's what doctors I thought were supposed to do. But they still got to pay their bills and light bills and so forth. And when those payments go down enough, they can't afford to do that. And what they're going to do, and they're starting to do it now, is they're going to have a concierge-type practice. They're going to move their practice out, and they're going to you're going to pay them cash, or you're going to pay them a certain amount of money. I do that right here in Washington, D.C. right now, so that I can see a doctor here if I need to. And then you filed your insurance. Whatever you got, that's a contract you have between the government, not between me. I will see you, take care of you, be glad to. And unfortunately, people without means are going to be left standing. They're going to go to the emergency rooms to get their care like they've always done. And that's the unintended consequence of what's going to happen. Now, the 6, I would suggest when we nominate people, we give them a roll of duct tape, too, to put over their mouth so that they don't say stupid things. And maybe we can win an election. We should have won 3 or 4 Senate seats last time. We did not. We can win 6. I don't think there's any question about it. We've got some great candidates out there. Some that I know, Tom Cotton, Bill Cassidy, and others, and I think the 3 from Georgia, your home state, that are running, great candidates that are running for Senate. We've got some really good candidates, and it starts with that. And then we've got to go out and get behind our candidates and not pick every little thing. They didn't vote for the Farm Bill, they did vote for this or that. Let's get on our team instead of handing the ball off. I'm the quarterback, and I hand the ball off to my halfback, and then I tackle him. Let's quit doing that. Let's get behind our guys.
But your question on strategy, Jack Kemp had 4 or 5 votes in the late 70s on tax reform that were losing votes until this passed. And what these guys are doing and what other conservatives in Congress are doing is putting our ideas out there. So we can actually pass these things through the House. John Boehner should put these bills on the floor of the House. We should be able to express what we're for. Do it year in, year out. Maybe we do it this year and it gets killed in the Senate. Maybe we do it next year and it passes the Senate and goes to the president's desk. But we're trying to gain the trust of the American people here. And it's a campaign to do that over and over again. Same way Jack Kemp did it.
But I think also that there's a strategy of really trying to build the conversation that this does need to be bipartisan. And the president keeps saying, oh, the Republicans have tried to repeal Obamacare 40 times. Well, many of those bills not only have become law, and because they're targeted at specific things like repeal of the 1099 rule, but a lot of the others have had huge Democratic support. As many as 30 or 40 Democrats have signed on. Once you begin, I think the closer you get to the 2014 elections and the more scared the Democrats get, I think there's going to be more and more of a call to make some fundamental changes. I don't think the president is ever, for the next 3 years, he's not going to sign a repeal law for Obamacare. But there are some strategic things that could be done that really would significantly delay this law, like a delay of the individual mandate, like a delay of the employer mandate, like not requiring people to have health insurance that has so many mandates and so many benefit requirements that nobody can afford it. I think you're going to start to see Democrats making some demands for legislation and trying to get that through Harry Reid. And maybe that's, again, my optimism, but I think it's also some political reality.
Yes, right back here.
I wanted to ask you about the Medicare SGR reform deal that came out last week, and it gets to the provider issue, but really doesn't do the hard part, which is dealing with the offsets, making those necessary reforms that have actual permanent solutions and savings. Rather than go through price controls or manipulating parts of the program, do you think conservative lawmakers are ready to embrace some structural reforms in Medicare that do have a history of bipartisan support?
I do. I mean, there are a number of areas where, whether it's combining Parts A and B, whether it's increasing age of eligibility, whether it's increasing premiums, the kinds of things that make it so the system actually can work. It's important to appreciate that the reason many of these reforms are necessary is because the program's going broke. And that's not Tom Price or Phil Rowe saying it. That's the Medicare actuaries. Within the next decade, the Medicare is bankrupt. Now, what does that mean? That doesn't mean that they go out of business. No, it just means that they could no longer provide the services that have been promised to seniors. Again, harming people. So it's incumbent upon us to reform and save the system. That's what Republicans have been trying to do. The problem is we haven't had a willing partner on the other side. So in order for the kinds of things that we know absolutely must be done, in order for the kinds of things that have had bipartisan support, actually some of them have been included in the president's budget. But then when we bring them up as possible opportunities to move legislation across the floor of the House and the Senate, the administration says, oh no, well we only meant it if it was in context with everything else. Or Harry Reid says, no, we can't do it in that targeted fashion. So we've got to have a willing partner on the other side, and that's where the whole issue of the politics of it. But we're not going to change this from Washington, D.C. This has to be changed from across the country. This has to be changed from the American people standing up and saying, we want our representatives to represent us, not the party. We want our representatives to represent us, not the administration. And as long as the American people fulfill their citizenship responsibility, and bring to Washington, elect to Washington, folks who are interested in solving problems, not just getting in the way, that's the solution.
Here's where Dr. Price is right. As long as it's still working for, as long as my mother, who's 91, can still go to her doctor, still get everything done that she needs to get done, it's not a problem for her. I mean, we just see these numbers and all this, and we realize that, and you know that for every dollar you pay in as a premium, you get 3 out in benefits. Well, you can't continue to do that. We know that somewhere along the line, we're going to have to do one of those things that Dr. Price just mentioned. Well, look, I don't know about you, but I would put off studying calculus till the very end. I hated it. And and I wasn't very good at it. So I put that off till last. Reforming Medicare is why it gets put. It's hard, and it's going to be painful. And the reason we didn't put it in our health care bill, we left Medicare and Medicaid specifically out of that bill, because that's a whole nother debate how you deal with those, and we didn't want to get bogged down with that. But you're absolutely right. The SGR reform, the policies are agreed on. The real tough part's who pays for it. And this is me, I'm on Medicare. The thing I thought was the silliest thing in the world, I turned 65 one day. Nothing happened to me. I just got to be 65. Nothing changed. I had a health policy the day before. Now I got alphabet soup, A, B, C, D, to try to figure out how all these work together. With Ryan plan, and I think it went on before that, even with, I guess, Simpson Bowles with that plan, where you have premium support and allow people just to buy a health insurance plan. I'd like to have just bought a health insurance plan, maybe kept the one I had the day before. I would have been perfectly happy with that. If I could have purchased it, I could not because of the way the rules are set up. So that's a big lift, but it's a lift we have to do, and as Grace Marie said, we have to do it in a bipartisan way.
Good. We have time for a few more questions. Our next speaker's running just a little bit late, so we can go down here.
Thank you. My question is to Congressman Price. Congressman Rowe, appreciate your bill ideas as well, but you mentioned that you don't want to be bogged down in questions of Medicaid, for instance, and your bill does include that, so I'm going to ask you a question. Because prior to, or leading up to Obamacare, we were already very close to where over 50% of the country already has government paying for their health care. We know that half the babies in the country are paid for by Medicaid. So I think that is very important to discuss this elephant in the room, and perhaps even sooner than getting to the point where we can reform Obamacare. So what my question is in your legislation, you're giving these Medicaid and S-CHIP beneficiaries a voucher to purchase a private plan, which I think is an absolutely excellent idea, and there are many others that agree with me, including Dr. Ben Carson. What I'm wondering is, why are you putting it in the middle of another plan? Is there a strategy behind it being here and not outside as a self organism, so that we can have something to go to media with and to have a national discussion during these 3 years of waiting to get to the opportunity to repeal Obamacare? If the answer is, well, we just wanted it this way, is there anyone else of your colleagues, because someone mentioned that there are 150 bills running around there on health care, or any one of them specifically and only looking at this particular area?
Yeah, no, it's a great question, and we've peeled off a number of different pieces of 2300 in individual separate bills. 2300 does a lot more than I talked about, and you pointed out the ones that provide for individuals to utilize and to have states have the flexibility to utilize the resources that they have for Medicaid to provide individuals an opportunity to buy something that they would want, as opposed to be stuck in the Medicaid system that they currently are. Right now, that's against the law. Exactly right. Exactly right. And it's a good point. I'll go back. I don't know that anybody has that specific piece of legislation that we included in ours as it relates to Medicaid, but we'll revisit whether or not that's something that we ought to peel off. Yeah. Yeah. Thank you.
Let me give you a real world example. I just left the emergency room the other day at my local medical center. We had 6 urologists in Johnson City, and 2 of them said, I'm out of here. I can't afford to put $250,000 in electronic health record at this point in my life. I'm retiring. So they retired. They all took Medicaid in town. Every single urologist did. They shared the load among all of them. What happened was, when those 2 urologists quit, they had so many other patients to see, they couldn't see them. I mean, they're lined up, people waiting months to get in. And so what do? They stopped taking Medicaid. So now what happens is, to get a urologist to see you, and you go to the emergency room, you have to get admitted to the hospital. To keep your privileges in the hospital, we have to see anybody who comes in. So stuff that would get treated as an outpatient now is admitted to a much more expensive, or it has to go 100 miles to Knoxville to get seen. Now, that's what's happening right now in reform. What Tom is talking about is that and I agree with this, we shouldn't have a different system for our lower income people. They should have a health insurance plan like I have. And I absolutely agree with what he's doing. We just didn't include it in our bill. So that's the part about access.
In terms of strategy, though, it's a great wedge issue, because we know that Medicaid is draining the state budgets. It's just a great wedge issue for us to make the case to the American people that government just didn't show up a couple of years ago in Obamacare. It's been moving toward a one-payer system for a long time.
Okay. Well, example, in my state, Tennessee, they are estimating this year that we take $192 million new dollars in. Our governor elected not to expand it. He wanted to have a plan where you could use price. So we didn't expand Medicaid. This next fiscal year, we expect just current Medicaid to take up $175 million of those dollars. So there are no more dollars for higher education, for K through 12, $17 million in a $30 billion budget. The Medicaid currently is taking up all the new dollars. So we have to reform it.
I would just underscore, too, that it's really a quality issue. I mean, this administration, it's a wonderful opportunity to contrast the different visions. This administration just says, well, we'll give everyone coverage. You can just enroll on Medicaid. Well, that's not the solution that we have. We want, as I think Congressman Dr. Rose said beautifully, we want low-income people should have the same access that the rest of us have. Why should they be cast aside to a lower-level quality care program? And I think it's really important to be able to expose that difference. You can have Medicaid, but as many of the beneficiaries themselves say them on their own, it's a card with no access behind it.
And that's really one of the reasons that so many states are resisting expanding Medicaid, because they know that without increasing the supply of physicians and hospitals, that you're going to wind up simply putting more people in waiting lines. The governors want to reform Medicaid so that the people on this program have the dignity of being able to see private physicians and being able to have private coverage and not be relegated to long waiting lines and having forced into wait for 5 or 6 hours in a hospital emergency room just to see a physician. I know you know that, Star.
Right here.
A blind man I know put it really well. He said, I just want to be treated like everybody else. My question addresses enforcement for either of your bills. Are you including in there anywhere for the patient's ability to read their files routinely and correct misinformation because it's now going to track? Addressing cases like Sanofi where they go after the drug company, are you going to start to go after the doctors immediately too that participate in taking the drugs for free? And then there's the security of patient info. A Target ID that's stolen is worth like 59 cents. A medical ID that's stolen is worth like $77.
The transparency that we have stipulates that individuals own their own health records, so that and that they control them, so they would have complete access to them. We haven't gotten down that's more a rulemaking specific regulation that would need to be put in place. But we've gotten we're decades away from when patients actually knew that they had the opportunity and privilege and right to control their own records. We've gone a long way down the wrong road, and it's going to take time to get that back. But you're spot on. Sure.
I'm reformed media. I actually write for myself now and say what I want to say. Stop quoting the New York Times from the committee hearing rooms, and whatever you say gets to the exact same place the New York Times gets to. Anything you put out travels the world at the exact same speed. So talk about your own stuff.
Thanks.
Time for one more, right here.
Asking you to extrapolate into the future. I have a son who currently is in medical school. How do you see this additional government intrusion into medicine? How do you think that is going to affect his life?
You know, last week or 2 weeks ago, I went to, we have a medical school in Johnson City. I was privileged to be on the clinical faculty for 30 years, almost 30 years, till I came to Congress, and I spoke to pre-med students and to medical students. And if I were back a young man now deciding, am I going to be a congressman, am I going to go back to the operating room, that's an easy decision. I go back to the operating room. Taking care of patients is still a fun, fulfilling thing to do. There are a couple of issues out there. I'm the son of a factory worker. My dad made shoe heels at a B.F. Goodrich plant in Clarksville, Tennessee. I was able to go to college and medical. My dad wasn't interested in one of these 6-year undergraduate programs. He was interested in me getting on out. So I went to college and medical school in 7 years and graduated with no debt. Young doctors now, and I didn't live large. I got to tell you, I ate a lot of chicken and a lot of stuff. I didn't live large, but I graduated with. Didn't realize I was eating good then. That's all I could afford. Young doctors now are facing a different climate than when I came. You're not going to be able to go like I did and hang your shingle out, and build a practice and take care of the same patients for 30 years. Insurance companies move them around, and you lose some of that loyalty, but you lose that physician-patient relationship. And I can tell you that is paramount. Some of the things I had to do to people, the cancer surgeries I did and so forth, it requires an unendearing trust to be able to go do what I had to do to people. And I would tell your son, you let Dr. Tom Price and me worry about that. Let that young man be the best doctor he can be right now. That's what I would tell him to do.
Folks going into, folks going in, I encourage anybody who has any interest to go into medicine to go into medicine. There is nothing more noble than caring for one's fellow man. There's nothing more gratifying. There's nothing more incredibly fulfilling, as Phil said, than taking care of people. So if your son, I'm sure, is going into medicine for all the right reasons, and he will be fulfilled because of that. Now, remember, this is a dynamic process. This isn't a static process. He'll practice probably 30 or 40 years, hopefully, God willing, and the creek don't rise. We are not living right now in the system that we'll have, I suspect, in 3 to 5 years, let alone 10, 20 years down the line. The technological capabilities of curing disease, of helping people, we're on the cusp of incredible innovation in the area of just curing disease. That astounding when you think about it. He's going to have the opportunity to be involved in that process. So I would encourage him to stay the course. And another positive note: I talk to medical students all across this country. And medical students, as you might imagine, cover the ideological spectrum. Many of them at their age start over on the left. They'll get to the right place as soon as they get out and recognize that again, it ought to be patients and families and doctors making medical decisions. When you ask them that question, medical students, regardless of their ideology politically, when you ask them, who do you think ought to be able to make the decision about your patient, how you care for your patient? Should it be you or should it be the government? They all answer correctly, regardless of where they are politically. That once they recognize that, in fact, there is really an affront on the practice of medicine, the ability for him or her to care for their patients, will be in the right spot.
And I think also the fact that there are about 20 physicians now in Congress that are making policy, they can't say this, but their colleagues really do look to them for leadership and what ought to be done. And the fact that they both have legislation out there is very important. I would tell your son to hang on, because things are going to change. The American people now get it. They want to be in charge. They want their doctors to be making decisions. I think the future can potentially be hugely bright. But thank you all for coming, because I think your voices are really important in helping people understand the changes that have to be made to get to that right kind of bright future in our health sector.
One antidote for your son. You can tell him, in the 30-something years I've practiced, I took care of some of the sickest people you could possibly imagine, never took a Tums or a Maalox. 6 months after coming to this place, I'm on a Prilosec every day. So
thank you. Please join me in thanking our panel. Thank you all for your commitment to this. Okay, folks, we're going to go right into our next speaker, and thank you. Please welcome Mike Needham back to the stage to introduce our next speaker.